Good evening, everyone. I'm Dr. Sanjeev Jaiswal, a consultant endocrinologist at Raipur, Chhattisgarh. I practice in Shankar Raipur. So today we'll be discussing about two peas in a pod, that is two different peas available in a single combination. So we know that diabetes is very prevalent in our country, and we are going to surpass China as far as prevalence of diabetes is concerned. And we know that diabetes is associated with various complications, being at microvascular complication, macrovascular complications. Microvascular complications like cardiovascular disorder is very important cause of increased mortality in type 2 diabetes, and nephrological complications like we have a renal complication. Some patients develop end stage renal disease, renal failure because of diabetes, and diabetes is one of the most common cause of renal failure in our population. So these complications, being at micro or macrovascular complications, diabetes per se increases the risk for these complications. And apart from the diabetes, there are various risk factors like hypertension. We have a dyslipidemia, obesity, increased waist-hip ratio, and family history of similar illness in our family. That these risk factors increases the risk factor of these complications significantly higher. So when we talk about any anti-diabetic medications, there are a lot of drugs available, including insulin for controlling diabetes. So why diabetes happens? Diabetes happens because of defect in one of the 8 amino octet. So diabetes, when we see holistic approach for diabetes control, we have to have a drug which control most of the pathway of diabetes. Like we have SGLT2 inhibitors like empagliflozin. We have DPP4 inhibitors like linagliptin or sitagliptin. So these two combination of drugs, they are very important for preventing complications of diabetes and also correcting the inherent defect in amino octet. This DPP4 inhibitors increases glucagon release and also has incretin effect, by which it increases insulin secretion from beta cell, also decreases hepatic glucose output. Similarly, SGLT2 inhibitors like empagliflozin, they prevent glucose absorption from proximal convoluted tubules. So these two drugs, they cover almost all the pathway of amino octet. So when we combine these two drugs for diabetes management, they are like a wonder drug for diabetes, especially type 2 diabetes management. And when we talk about the complication of diabetes, the cardiorenal complication of diabetes, as well as metabolic complications of diabetes, these two drugs, they have effect on, they have a better effect for cardiovascular as well as renal protection. These two drugs like empagliflozin, it shows cardiovascular protection as well as renal protection. And when we have linagliptin, it has a various mechanism of action by which it decreases hyperfiltration from kidney. So it has renal protection and also cardio protection. So when we combine these two agents, linagliptin as well as empagliflozin, the efficacy, glycemic efficacy is very well. Glycemic control is very good, and not only control, these two drugs, they have effect on cardiovascular as well as renal morbidities. So they decreases cardiovascular as well as renal morbidities. And there are various studies. When we talk about empagliflozin, there are Emperor trial, which shows that there is a decreased risk of heart failure, hospitalization for heart failure, also decreased risk of atherosclerotic cardiovascular disorders. So when we talk about linagliptin is the Carmelina study and Carolina study. These two studies have shown that linagliptin has a good role in prevention of mesangial proliferation in glomerulus in our kidneys nephrons, and also it has a good effect, cardiovascular effect, as far as type 2 diabetes patients concerned. When we combine these two drugs, there are few studies which have shown that the side effect of empagliflozin, which can be urinary tract infection or genital mycotic infection, can also be decreased when we combine empagliflozin with the linagliptin. So combination of these two agents, they work like a magic, and they have not only glucose lowering effect, they also decreases cardiovascular as well as renal mortality as well as morbidity in our patients. To conclude, I would say when we see holistic approach of diabetes, we have to see not only glycemic control, we have to see the comorbidities of the patients, microvascular complications, whether the presence of any morbidity is there, like in the form of atherosclerotic cardiovascular events, or hypertension, or heart failure, or renal failure. So based on that, we have to judge our patient. Based on that, we have to treat and start treatment. And each treatment should be individualized for our patients. It should be a tailor-made rather than a general blanket treatment for all the patients. So these two drugs, empagliflozin and linagliptin, they work synergistically, and they have a very good effect on glycemia as well as prevention of other cardiovascular, renal as well as metabolic morbidity. So thank you so much for patient hearing.
I am Professor Dr. Smith Srivastav, Head of the Department, Cardiology, Advanced Cardiac Institute, Medical College, Raipur. So today we'll be discussing how treatment of diabetes has changed over the years. Treatment of diabetes is no longer limited to just glucocentric approach or just saving few complications. Now it has become a big deal that we need to understand that it is many organs or a patient as a whole which is involved in diabetes. It has gone beyond just beta cells conservation or beta cell treatment or repletion of insulin. And that is because we now understand that diabetes is no longer a disease which is limited to just insulin deficiency, but it has multitude effects which include renal effects, which include microvascular and macrovascular effects, which include contribution to cardiovascular disease. And almost 70% of the patients who have diabetes, they perish not from any diabetic reason, but from coronary artery disease or cardiac complications. So we understand that every third patient who has diabetes would have a coronary artery disease. And if we consider for subclinical disease, we'll find that almost 60 to 70% of these patients, diabetic patients, would have some underlying cardiovascular disease which is subtle and not yet manifested clinically. In Indians outpatient setting, if we understand, if we take 100 patients with diabetes, we'll find that almost 2/3 of them will have intermediate risk for cardiovascular diseases. Half of them would be high risk. 1/3 would have a known cardiovascular disease, and 18% to 20%, almost 1/5 of them, would have suffered a cardiac event or had a cardiac procedure. So this is how we find that diabetes goes hand in glove with coronary artery disease and cardiovascular diseases. And to top on that, we understand that Indians are at a higher risk than the Western counterpart. Indians have more and early cardiovascular diseases, early coronary artery disease, early heart failure, early diabetes, and the complications of diabetes, particularly cardiovascular complications, they occur more and early in Indian patients, leading to early death and more death in these patients. So we have certain challenges, especially if we see in Indian patients and in Indian physicians, there are certain challenges that come in achieving glycemic goals. Physician related, we find that there is failure of many physicians to adapt to the traditional monotherapy to now a combination therapy or initiation of insulin. In medication, we still are stuck to the monotherapy with metformin. We do not assess, we still have a glucocentric approach. We do not assess these patients as which OHA or which anti-diabetic medicine would be required, would be better for these diabetic patients, suiting their profile. Patient related, patient has many, especially Indian patient, they have many whimsical, they have many, their underuse of medications, they are not they're reluctant to have injectables. They are very much concerned over adverse effects, and there is always a switching over or more acceptance to the traditional medications than proved allopathic medications. The evolving recommendation for initial therapy are no longer for monotherapy with metformin. The European guidelines, the American Diabetes Association, they prefer a combination therapy as initiation whenever the HbA1c is high, or even SGLT2 inhibitors or GLP as a first line drug rather than metformin in those who have a cardiovascular disease or have a high risk of cardiovascular disease. Diabetes is no longer only beta cell malfunction, but now we have an understanding that it has a wholesome play of glucose uptake by muscles, glucose reabsorption by kidneys, liver, hepatic production of glucose, incretin effect, and the abdominal fats causing lipolysin adiponectin mechanisms. The renal, cardiovascular, metabolic aspects of type 2 diabetes since 2013 have become the major target against which all the oral hypoglycemic or any new anti-glycemic agent is tested. The glycemic efficacy, now we understand, especially for Asians as compared to the Caucasians in type 2 diabetes, where we try to compare the efficacy for SGLT2 inhibitors as compared to DPP4 inhibitors. The SGLT2 inhibitors work better in Asians as compared to whites, whereas the DPP4 inhibitors work equivocally for Asians as well as the white. So probably SGLT2 inhibitors is one panacea that is more targeting the Indian population, the Asian population. And this was also seen in EMPRISE East Asia study, where the cardiovascular and the renal effectiveness of SGLT2 empagliflozin for reduction in hospitalization for heart failure in those patients who had cardiovascular disease or those who did not, it had an improvement in favorable improvement with empagliflozin. SGLT2 inhibition consequently improves the epidocytokine profile of the patient, and which tells us that probably empagliflozin, when compared with sitagliflozin as an add-on to metformin in type 2 diabetes, it results in reduced systemic inflammation, and there is an overall treatment of diabetes rather than only glucose lowering, which becomes important because overall systemic inflammation, if it is reduced, it results in lesser morbidity and mortality in the long term, lesser complications in diabetes. Another favorable outcome with empagliflozin as compared to placebo is 52% reduction in new risk or new onset obstructive sleep apnea. And this can be attributed to the property of SGLT2 inhibitors to actually squeeze out the tissue edema or tissue extra fluid rather than the intravascular fluid. So from EMPERIC outcome trial, we can have this data that tells us that this can be attributed to change in weight, a reduction of weight to the tune 2 to 5 kgs, reduction in systolic blood pressure, hematocrit, HbA1c, and finally obstructive sleep apnea. The new onset of gout or anti-gout medication, again, EMPERIC outcome tells us that it results in lesser hyperuricemia, a 33% lesser risk of new onset gout, and anti-gout medication use. Uric acid itself is considered to be an independent risk factor for cardiovascular disease. It is also a marker of a systemic inflammation. Any decrease in uric acid tells us that it is reduction in systemic inflammation. Empagliflozin, it confers early and sustained decrease in cardiovascular death in patients who have atherosclerotic cardiovascular disease and type 2 diabetes. Again, from EMPERIC outcome, overall there is 38% reduction in the study population as compared to placebo in Asian patients, Particularly, as I said, empagliflozin is a drug which is probably designed for Asian diabetic patients. It has almost double risk reduction in Asian patients of 56% as compared to placebo. Empagliflozin lowers the cardiovascular death and heart failure hospitalization in patients across the spectrum of heart failure and across the spectrum of different cardiovascular diseases, whether it is cardiovascular death and heart failure hospitalization combined, heart failure hospitalization itself, cardiovascular death, first hospitalization for heart failure or recurrent hospitalization for heart failure. In heart failure, especially in heart failure with reduced ejection fraction and in certain heart failure with preserved ejection fraction, empagliflozin works throughout the spectrum of heart failure. The Carmelina trial, which had cardiovascular safety and clinical outcomes with linagliptin, it was first single study that investigated both cardiovascular and renal safety of linagliptin in around 700 patients. A total of 62% patient had a baseline which was lesser than 60. It demonstrated that an assuring long-term cardiovascular and safety profile with reduction in albuminuria. So for empagliflozin, for SGLT2 inhibitors, it primarily is a drug which has come for rescue for the cardiologists to reduce heart failure admissions for heart failure events and cardiovascular events, and it has become the first drug that is often prescribed prior to heart failure drugs, because the core cardiac anti-heart failure drugs, they need many considerations. There are many ifs and buts before we start these drugs to watch, whereas SGLT2 inhibitors like empagliflozin, they offer us a very safe initiation of the therapy in heart failure patients, and then later on the core cardiac anti-failure drugs can be added. I thank the organizers for giving me this opportunity to present my thoughts on SGLT2 inhibitors, especially empagliflozin, and where it helps a cardiologist in treating his patients which may be diabetic or may not be diabetic, but definitely have a increased risk for heart failure and for atherosclerotic cardiovascular disease. Thank you.